Well, good evening. I'm Anton Pozniak. I'm the president of the IAS and co-chair of this conference. And my other co-chair, Brenda Crabtree Ramirez, is here with me tonight. I'm really pleased to welcome you all to the official opening press conference of IAS 2019. And this is all around, is the global HIV response in crisis? I'd like to add a special welcome to those of you who are joining us online. This session's been live streamed and a recording will be posted to the conference website. In a moment, we're going to hear some brief remarks from our panelists, and then we're going to take your questions. Now, first, allow me to set the scene. Over the past several decades, we've made remarkable breakthroughs in science and technology that have completely changed the way we think about HIV and how we treat and prevent it. And this conference is going to be primarily focused on the research that's done that, but we have to understand the impact of natural and man-made disasters on fueling the HIV epidemic. In humanitarian crises from Syria to Venezuela, the challenge of providing HIV services challenges our progression in confronting the epidemic. People in emergency settings, political or due to natural disasters, are especially vulnerable to new infections. We must work to ensure that HIV prevention and treatment are an integral part of all global relief efforts. We're also going to discuss HIV outbreaks, mainly in children, which appear to be a man-made disaster, the crisis in South Africa of infections amongst young girls, the rising epidemic in Eastern Europe, and finally, what the response to these challenges might be. So, our first speaker is my co-chair of the conference, Brenda Crabtree Ramirez, and she will discuss the state of Latin America's HIV epidemic, a region of the world which is no stranger to humanitarian crisis. Brenda, please go ahead.
Thank you, Anton. And hello, everyone. Thank you for being here. I'm pleased to welcome you to Mexico City. It is an honor to serve as a local scientific chair in this conference. Hosting this conference in Latin America offers an important opportunity to focus on HIV in our region. While other regions have higher rates of infection, HIV remains a challenge in Latin America, a challenge compounded by political and historical inequities. In 2017, UNAIDS estimated that 1,800,000 people in Latin America are living with HIV, a prevalence of 0.5%. These cases are highly concentrated among vulnerable population, including men who have sex with men, transgender women, sex workers, and people who inject drugs. Over the past 20 years, we have seen significant efforts to expand ART across the region. A decade ago, the International AIDS Conference took place here in Mexico City, and we have continued to scale access to treatment. But political and social economic shifts are threatening any progress we have made. We have the highest rate of trans murder in the world. Rates of HIV and AIDS-related deaths have barely changed in over the past 20 years. In some other countries like Chile, Costa Rica, and Guatemala, incidence is on the rise. Moreover, each year since 1996, 40,000 people die because of this epidemic. Driving these numbers are inadequate prevention effort. PrEP uptake remains low, and a lot of needs to be done in the preventing mother-to-child transmission. Additional political instability has affected Central and South America, forcing hundreds of thousands of people from their homes and disrupting their access to healthcare. Those who have stayed face failing health systems. Of the 120,000 people in Venezuela living with HIV, less than a half have ART access, and less than 10% are virally suppressed. Addressing our region problems means addressing inequality. Latin America remains the most unequal region in the world. We need political will and strong investment to ensure that we are reaching everyone. especially in scaling prevention efforts. These efforts must be tailored to the changing needs of the region. We must provide the information, education, and prevention that young people need to stay HIV negative. We must make services available to migrants, and we must break down the violence, stigma, and discrimination that keep trans people, sex workers, MSM, and people who inject drugs from accessing services. All of these efforts must be evidence-based. My hope is that the studies that we will present here this week at IIS 2019 will start a conversation about what we can do better. Thank you very much.
Thank you, Brenda. Our next speaker is Abdool Karim, who is a professor at Columbia University, an associate scientific director at the Center for the AIDS Program of Research in South Africa, otherwise known as CAPRISA. She will address how access to services for women and girls are under threat. Please go ahead, Quarraisha.
Thank you very much. Good evening or good afternoon to all of you. So, young women between the ages of 15 to 24 in sub-Saharan Africa have some of the highest rates of HIV infection. In fact, about 1,000 infections take place each day. And when you think about in the global context, we're seeing 5,000 new infections. 1 out of 5 of those are taking place in young women. Young women between the ages of 15 to 24 have up to 6 times more infection compared to their male peers. And some of this risk is associated with a combination of behavioral factors, biological factors, as well as structural factors. So if you think about behavior, one of the key drivers is the age-sex difference in that young women are acquiring infection from men who are 5 to 7 years older. In terms of biology, we've learned that vaginal dysbiosis is really a key driver. We don't understand what the cause of this is, but it enhances HIV acquisition and also reduces the potency of some of the new technologies that are becoming available. In terms of the structural drivers of this, poverty is a key issue. But in addition to poverty, what we also see is high rates of gender-based violence, and in situations of conflict, that is exacerbated. But fundamentally, when we're looking at HIV in young women, it is about gender power differences and how those are exploited under normal and even crisis situations to aggravate and exacerbate an already vulnerable population. What we do have is this problem, and what is available to reduce the risk is actually female condoms and PrEP. And both of those have young women have limited access to. And at the end of the day, there may be new technologies further down the line. But right now, young women need integrated services that address prevention of pregnancy, prevention of STIs, and reduce the HIV risk. Again, all of these factors in conflicts, in natural disasters, put young women at a more vulnerable stage because of their limited power to negotiate and limited protection within society. Reductions of HIV infection in young women could really dramatically change the current trajectories that we're seeing, poor progress in preventing HIV infection, and really set us on a more positive trajectory. And that's really what is at the heart of any investments we make and focus in young women. Thank you very much.
Thank you, Quarraisha. Now, our next speaker is Fatima, who's an assistant professor of pediatrics at the Aga Khan University in Karachi, and she's going to discuss the pediatric HIV outbreak in Pakistan. Thank you.
Thank you, Anton. Thank you for having me here. I represent an academic institution, but I have been working as an HIV physician along with the Sindh AIDS Control Program, which is the province in which this outbreak took place in the end of April. Just to give you a backdrop of what HIV in Pakistan is like. It's a concentrated epidemic. It's driven by intravenous drug users. Children somehow never featured much in the HIV scene in Pakistan. And very few children, I think we have 1,000 were registered from about 35 centers across the country till March 2019. And in the end of April, basically, a thalassemia care center, which took care of children who received repeated blood transfusions, called me in Karachi, and they said 46 children had screened positive. We informed the National AIDS Control Program, and within 2 days, 14 more children were reported from a nearby town. So this was the first time an unprecedented number of children was screened positive. When the government mounted a response, and they called in different stakeholders, UN agencies, academicians, government people sat together, and we came up with a plan. And through population screening over 3 months, literally 32,000 people have been screened. 997 are positive, out of which 776 are children. So it's basically created a lot of burden on a program which is not geared towards children. It was geared towards high-risk groups. Now, what has been difficult for us is that Larkana is a district which already has poor health indicators, and this is a population with a very high under 5 mortality, a high infant mortality, a high prevalence of malnutrition. And just because of the malnutrition, most of the children, they qualify as clinical stage 3. So we have had to, from scratch, set up a pediatric HIV center over there, train physicians who are not used to children, let alone children with HIV, to deal with HIV, and it's a very algorithmic management right now, but with time we hope that it's going to mature and become better. The government, on the other hand, and I have the deputy program director with me over here in the audience, they have mounted a multi-pronged response which includes infection control. There was an initial investigation, a detailed investigation is going on right now, case control study, which I'm leading from Aga Khan University. But basically, the hypothesis which was generated was very few children's mothers were positive, very few children had received blood transfusions, but almost every child had had repeated injections for any illness. So just the practice in Larkana is that for any childhood illness, people will go and demand injections. And because there are a lot of unregistered medical practitioners and there's malpractice, there's reuse of injections, there's reuse of needles, and so the spillover in the general population is extremely alarming for the country as a whole.
Thank you very much. Now, our next speaker is Momchil Baev, who's the Sexual Health Program Manager at Single Step in Bulgaria, and he's going to cover the rising epidemic in Eastern Europe and efforts to eliminate stigma.
Thank you, Anton. Thank you for having me at this beautiful forum. And like Anton mentioned, I represent not just Bulgaria, but I will be speaking a few words about another diverse region, the one of Eastern Europe. As you know, we have the science and technology at hand to fight the epidemic. It is time to eliminate stigma and discrimination. It is time to close the gap between the East and the West. Eastern Europe is the only region in the world where the HIV is on the rise, with Russia alone contributing 100,000 new HIV infections per year. Let me remind you that Eastern Europe is a very diverse region when you have countries that are members of the European Union, such as Bulgaria, Romania, but we also have Ukraine, Russia, where situation is a lot more different and difficult. To reverse this trend, we need interventions that acknowledge and address the needs of those that are at most risk for acquiring the HIV infection. Those are the men who have sex with other men, trans people, injecting drug users, and sex workers. Having in mind that the Global Fund is just withdrawing from several countries in Eastern Europe, that poses a great challenge before the national governments to provide funding and sustainability to the services that were created by the Global Fund in the past at least a decade. We need more broader cooperation between national governments and community organizations like ours to form allies that will tackle the HIV epidemic. In Europe, we do have the resources to fight the epidemic, but it's stigma and discrimination what keeps us away from the right path. It's still not okay to talk about HIV status openly. People live in hiding, and this is part of a big stigma that's a burden on the communities that we work with. It is also very important to scale up testing services, and this is the only way we're going to reach out all those invisible communities, the MSM, the trans people, the sex workers, injecting drug users. Of course, providing home testing would be a great opportunity to allow for those people to get tested without having to see a physician, without having to travel to a testing center. Having an opportunity for home testing would definitely make an impact, as we show in one research that we recently carried in Bulgaria, and I'm going to present tomorrow. So to summarize, Eastern Europe is, I would say, a developed region, as some of it being part of the European Union, but we still have other countries in the East that need to take political lead and face the HIV epidemic and eventually solve it together. Thank you.
Thank you, Momchil. Our final speaker is Ambassador Deborah Birx, who's the US Global AIDS Coordinator and the US Special Representative for Global Health Diplomacy. Deborah will share the PEPFAR perspective and discuss what's needed to control the global HIV epidemic in face of some of the challenges we've covered here today. Debbie, please go ahead.
First, I want to start by thanking the co-chairs and the scientific committee for putting together really a brilliant conference. I mean, you really should be applauded. It's a great mix of two issues. Why have some countries and some populations succeeded in decreasing the rate of new infections and others have not? And our job is PEPFAR, because the United States is the largest investor in HIV/AIDS. We're a third of the global fund investment. We're almost 40% of the investment in UNAIDS. And the American taxpayers expect a great response both from our bilateral programs as well as our investment in the global fund and the multilaterals that bring us such rich data and information. This scientific gathering is a unique gathering, and we always have to remember that HIV/AIDS conferences are very different than other infectious disease and other disease conferences because it respects and always brings the community and the client to the center. Yesterday, we had 3 fantastic pre-symposiums, and again, I want to thank the co-chairs for putting them together, addressing where our key gaps are, understanding the progress we're making towards cure, understanding where we are in the TB and the TB/HIV epidemic and what we can bring to the TB epidemic, and then a really incredible symposium on men and understanding why men are accessing treatment late and why more men are dying from opportunistic infections at this time. So no matter where you look in anywhere in the world, there are countries beside one another where they've made great progress next to a country with a very similar epidemic that hasn't made progress. And you see this in sub-Saharan Africa, you see it in Latin America, you see it in the Caribbean, you see it in South Africa, you see it in Central and Eastern Europe. We have the Ukraine making progress, we have Russia rising new infections. These are the stories and these are the science and the behaviors of both politicians and political will and leaderships within the health community coming together in partnership with the scientific data. And so we're always excited to be here because we're seeing some real dialogue this year and trying to understand why, and just a group that's going to be talking tomorrow or Tuesday will be looking at large clinical trials of different interventions to see why you could you decrease incidence with prevention and treatment interventions. And we had very different results in countries beside one another. I think this provides us the opportunity to dig underneath the scientific evidence into the policies and behaviors and community and access and what you talked about with stigma and discrimination. Young women incidence is rising in many cases, but decreasing in some countries. It has to do with, do the young women believe they have access to the information and the prevention and the treatment that they need? Are they welcomed in the clinic? Is it a space where they want to engage with the health provider? Or is it an unwelcoming space? These are answers and questions that we have to ask ourselves, or there will never be really universal healthcare coverage unless there is access. And I think what HIV/AIDS has pointed out, that building it does not make them come. And it's the work that we need to do within the community, and it's the work that will be coming out the next 3 days in this meeting that really will give us the behavioral issues and the way that we need to readdress the fact that the client and the community needs to be at the center. I think IAS has always run meetings so that that is true. Yesterday at the men's forum, we started with the community. I was so impressed by the first panel being men talking about what's keeping them from services. This is what we're here to do. We're here to listen so that we can bring the insights from this program to PEPFAR. We're in just 56 countries. We're not in the entire globe, but they're the 56 highest burdened countries. And our job is to work with governments and communities to ensure that our resources are translated into impactful programs that will change the course of the epidemic. We have examples that it can be done. Now we have to ask, why isn't it done everywhere?
Thank you very much, Debbie. Okay, so now we'd be very happy to take your questions. And if you have a question, can you come up at the microphone? I think we've got one either side here. And when I call on you, can you please start by indicating your name and your outlet? And always the impossible ask, keep the questions short, please. So if there are any questions.
Thank
Okay.
you.
Yeah.
My name is Sergey Abdurrahmanov from AIDS Center, Russian website about HIV. And I would like to ask you, it's not a secret that one of the most important news of this conference is about dolutegravir and neural tube. And I would like to ask you to explain why dolutegravir is so important for the HIV and for medication.
Well, we're going to have a press conference about that tomorrow morning, so that would be great if you come along to that. And the WHO new indications have got very good, the data's all in there, but in brief, it's cost, it's very low, it's very good tolerability, it's highly effective, and it has benefits when you look at many, many parameters. And all that's in the report. It's all going to be tomorrow morning, and I would encourage you to come along.
Okay, thank you.
Oh, sorry, hi.
Hi, my name is Nicholas Diamond from Boston University School of Public Health. We heard earlier that 1/3 of the presenters at the conference this year are under the age of 35, and we also heard from Professor Abdool Karim that there is an increase in youth and young adults being disproportionately affected by HIV. I'm wondering if you could speak to the importance of engaging youth and young adults in the next generation of first responders to the epidemic.
Okay. I think that's an excellent question. In many parts of the world, we're seeing that, and particularly in low middle income countries, about 65% of the population is under the age of 35. And I think about myself, having been involved in responding to this epidemic, both as a scientist and as a program manager, that what we're seeing is a whole new generation of young people who've not experienced the early days of the epidemic. And so their perception of risk is not guided by some of what we experience in seeing the face of AIDS, seeing the devastation prior to the availability of antiretroviral treatment. And so I think in this era where we're seeing a whole new generation of young people, a whole generation of young people at increasing risk of HIV acquisition, that their voices to be heard, their voices to be seen, and to be shaping that response is absolutely appropriate. And I think that's what you're seeing in the conference, that they're putting not just lip service, but the visibility of that. I think the other piece is around the visibility of women, and this must be one of the very few panels in any meeting that I go to where there are more women speaking than men. And we don't, so I think now that's certainly cause for celebration. So in short, yes, young people needs are great, their voices need to be heard, and they need to lead the response and lead the solutions that we need to come up with. Thank you.
Quarraisha, I just wanted to add there are a majority of presenters here, 52% are women, right? So that is a fantastic change over the years. Fred.
Yes, Fred Scheich with IFARA TV. My question is to address to the gentleman from Bulgaria and also Deborah Birx. I know we've already talked about youth. Well, it seems as though that's where it is, and the biggest challenges are in Eastern Europe. Maybe you could both address maybe one or two things that you've done that actually been a positive to move forward in this area.
Well, I would like to give you a good example from Eastern Europe. It's from my personal experience. What we did in Bulgaria was introducing home testing for the first time ever in the country. HIV testing services in Bulgaria are institutionalized, and HIV tests could be performed only within healthcare institution. There's only one community center in the entire country that's located in the capital. All other testing centers are located within the healthcare institution. So going there, you would need to present your ID card and say why you need to enter that building. So the testing itself could be anonymous, but going there, you have to disclose who you are and why you go there. So that's not really confidential and anonymous. That's one thing. Another thing is that outreach services, after the Global Fund withdrew from the country, ceased to exist. So there's not much done in terms of reaching out to the vulnerable communities. We came up with the idea to provide the opportunity for those communities, especially men who have sex with other men and trans people, to perform HIV tests at home with an oral swab. And let me tell you, I will just give you two numbers. More than 30% of the respondents had never tested for HIV in their life. And those are, let me remind, men who have sex with other men, who are sexually active, and they had sex with another man in the past 12 months. So that's a very big number. There's a majority of this population that we studied that hadn't tested for years, or they don't use condoms on a regular basis. So I will be showing more of those numbers tomorrow at 1 o'clock in the poster area, and I'll be happy to speak more about this example. But I'm showing this as a good example that home testing could reach to those communities that haven't been reached by the public health services. The Ministry of Health has been doing a lot over the years, but apparently services need to be tailored to the needs of the communities. We can't have one size fits all. You can't test, you can't provide service for the general population that are the same for the drug users or sex workers or MSM. It just doesn't work this way. So that's one good example. Was that your question?
Yes.
I'll be very brief. In looking at the depth and breadth of the epidemic, we convened a meeting in Bangkok of Asia, Central Asia, Eastern Europe, and Central Asia to really work through what was holding us back, because we had money in the region, both PEPFAR and Global Fund, but we weren't making the same progress we had made in other regions. We had the government and communities there. And when the government and communities agreed together to change the policies as you just described, access to testing, access to services, community actually able to deliver testing and treatment services, we were able to increase our investment in those regions. If we kept doing more of the same, we were going to have more of the same outcome. So governments and communities who are willing to utilize our dollars in new ways to have a new impact. And I think you raise another critical question and issue. As these epidemics evolve and move into younger and younger age groups, or move out of their traditional risk groups, in many parts of Eastern Europe and Central Asia, it was primarily people who inject drugs. Now you're seeing a very young MSM population. We have to change to meet those needs. We can't continue to do the old programming. And I think that's difficult for all of us to change. It would be like treating a 5-year-old the same way you would treat a 15-year-old. Your 15-year-old would not let you do that. So you have to evolve based on where the epidemic is going and then invest in those areas. And I think governments who are willing to recognize the critical role of community in leading services and accessing services and actually peer-led services, we're increasing our investment. And I think if we see this kind of change, we're very excited about that change and the policy change it brings with it.
Thanks.
Hi there, Peter Hayward with the Lancet. This question for Fatima Mir. What are the age ranges of the children that you're seeing, and does it seem that these are sort of all new and it's a very acute problem, or does it seem to be something that's more long-standing? And then also, obviously this is just one area that this is identified in now. Do you have any idea of whether similar things are happening elsewhere in the country?
So for the first question, most of the children are between 2 and 5. And so about 60% children are between 2 and 5. I can't give you the exact numbers now, but if you come on the 24th, we will be presenting the Pakistan data. Most of the kids, almost 80% of the kids are in clinical stage 1 and 2. So that suggests early infection. We have started collecting blood for phylogenetics, and we have results of about 120 of the 406 we will collect blood on, and they seem to be the same serotype. We aren't sharing this information right now because we don't want to extrapolate from very, very few of the samples. The other question you asked was, So the initial, just by testing the mothers, we know that most of the mothers are negative, and we know that very few have a history of blood transfusion. Larkana is a place where in 2016 there was a outbreak in a dialysis center because of unsafe and unscreened blood. So this is a place where you have a sex industry. This is a place where you have intravenous drug users. This is a place where you have unsafe, unscreened blood. So there is circulation of the virus in the population. And this spillage into the pediatric population, we feel, is because of poor injection practices and because of reuse of injections. But to prove this, case control study is going on right now.
So do you just think it's localized to this region?
No, because there's another town in Sindh called Hatri, and there's a small outbreak going on over there. Punjab, the largest province of Pakistan, so to date in Pakistan there have been around 9 outbreaks. Only 3 of those have been published and written up, and the rest, the reports are not for public viewing. So this time what has been excellent from the province of Sindh's point of view is there's been a transparency, there's been sitting together of different stakeholders, and there's been a sharing of results, and we want to come up with a national strategy now because we feel that with the kind of injection practices which happen in Pakistan, they're prevalent all across. So this means there will be more children. And to date, even the screening which is going on, each day there are 2 or 3 positive, 2 or 3 positive. So that means the chain is going on right now.
Hello, my name is Winnie from Nairobi, Kenya. My question is actually for Ambassador Birx. Just recently, PEPFAR reduced funding towards HIV in Kenya from around 55 million, I think, or billion, to 35. So my question is this the right time, I mean, given a few months towards the UNAIDS 1990 target, by 2020, I know the government has rolled out UHC in some parts of the country, but now is this the right time to sort of start reducing funds? And if that is the case, then what next? Is the government supposed to fund? Are we on our own, or what next? Thanks.
Yeah, I think that's a great question. So our job constantly, obviously we're in 56 countries, is we have to look across all countries and look at equity and need. And obviously there's a lot of need and a lot of services that need to be delivered. We also did a complete analysis of our investment historically of both Global Fund and PEPFAR dollars. And Kenya has been funded at a greater amount equivalent to South Africa. $6 billion of Global Fund and PEPFAR dollars have gone into Kenya for the same size epidemic as Zimbabwe. Zimbabwe has an investment of 2.5 billion over the last 15, 16 years. So that really raises a question about, are we utilizing the dollars as efficiently and as effectively? So the country operational plan process for Kenya took a significant additional amount of time this year because we wanted to make sure that the investment that we were making, the $350 million we were making again this next year, was appropriate for the size of the epidemic, what was needed, what was still the outstanding need, making sure that we could reach not only the 90-90-90, but 90-90-90 across all risk groups, ages, and sex. And we will be able to do that with the $350 million. I think, though, the bit broader question is, what is the government of Kenya investing in the HIV/AIDS response? I just told you $6 billion from the US and Global Fund. I think the government of Kenya hasn't even invested close to $1 billion. I would say less than $500 million, maybe close to $200 million in that same time period. And so these are really questions for the long run that we're working with countries on. But we would never compromise, and our commitment in PEPFAR and the US taxpayers' commitment has always been, if we start someone on treatment, we are committed to maintaining them on treatment until there are other resources that can be utilized. So I can promise you no Kenyan will fall off of treatment because of the change from the investment from 500 million to 350 million. 350 million is one of the largest investments we make in any country.
Okay. Yeah, go ahead. I think you, go ahead and then, yeah, all right. We've got time for these two. Off you go. Oh, okay. We're all being super polite, so please, ladies first. Yeah, there we go.
Thank you
there we
so
go.
much.
Yeah.
My name is Margherita Enrico from Italy. I'm an Italian activist. I live with HIV since 22 years, maybe. And my question is probably is a little bit complicated. It's about U equals U. And my question is, what is your total commitment about this revolutionary, the force of the message of U equal U? And also, this question is for Yas, is from the ambassador, from for the Yas. But I want to know also is, in country like Bulgaria or other country that you represent, which is the impact of this destigmatizing force of this message? Because in Italy we are in trouble about this, but I would know other country and yes also what thought about this, and what is the commitment about this?
Well, from the IS point of view, we're totally behind the concept of U equals U for sexual transmission. The science shows that there's no transmission if your viral load's undetectable. So we are absolutely behind that message. You asked about U equals U in Eastern Europe. Perhaps we could go there, and then perhaps we could talk to you, Quarraisha, about the impact of that in South Africa.
Thank you. Well, U equals U is also a campaign that we have in Bulgaria. It was translated to the local language, obviously, and it has made an impact, to be honest, at least within the gay community, where the campaign was more visible. It was actually directed mostly at the gay community, the MSM group in general. U equals U is important not just for the patients themselves. Of course, as you know, that helps them live a healthy life and have fruitful relationships, reduces also stigma. But it's also important for the broader public, for the general population, because as we speak about stigma and discrimination today on several occasions, it's stigma what kills people living with HIV. Many times that's what drives them in hiding. And when more people realize that undetectable means untransmittable. That will allow people to stop hiding and to be more open about their HIV status. That will change their life completely. So U equals U is also important in Eastern Europe, especially in countries of the so-called former Soviet bloc.
Thank you. Could you just want to have a quick ad
Sure.
to that?
So in South Africa, that's also at an individual level an important concept that is being promoted. But I want to add that because our incidence rate is so high, that we're finding a whole range of new infections. So U equals U on its own is not going to be sufficient. We need to combine that with stronger prevention options, and particularly the promotion of PrEP in uninfected individuals to offset these high incidence rates and what we can prevent through U equals U.
Thank you. So final question, I think now. Please, you've been patient.
Thank you. Khalil Wadigi from Coalition Plus newsletter. So we tend to hear a lot from HIV program managers about reduction of HIV incidence and not so much about reduction of HIV mortality. Last week, UNAIDS released its report for the epidemic in 2018, and that showed that the mortality figures are actually very worrying, and that the world is completely off track to achieve the targets it had set for itself for 2020. So our understanding is that the projection for when those mortality reduction targets will be reached is not 2020, but 2029. So it's a complete failure on the mortality targets. MSF reacted to the figures by pointing out that even in the most developed countries, you still have 20 to 25% of new HIV diagnoses that are at advanced stage, so less than 234, or with symptoms of opportunistic infections. So I guess my question is, what does that tell you as HIV program managers about the focus that has been given to the parallel goal of reducing AIDS mortality? Have we dropped the ball? MSF was pointing out that in many places where they work, the medicines that treat opportunistic infections are simply not available, nor are the tests. So what are your reflections about how we rising, how we providing for healthcare for people who are, despite all the efforts, who are only being found with very little immunity?
Okay, well, we've got a minute before we have to leave. Quarraisha, you could just comment on late presentation and mortality and why we're not getting there. Because Southern Africa is
Sure.
an epicenter of
I
that.
think it reflects also the way services are being provided. And one of the biggest factors that's linked with mortality is the co-infection with TB. In fact, co-infection, HIV, TB co-infected individuals have up to 70 to 80% higher death rates, particularly if it's MDR and XDR TB, of course, going up. So it points to the importance of not just treating the AIDS disease, but also looking at other comorbidities that may exacerbate or undermine the benefits of ARV treatment. So that's my sort of brief response to that.
Okay, thank you very much. I'm sorry we're coming to the end of the time because we have to start the conference now. I'd like to thank you all for joining us and those of you online too, and we look forward to interacting with you in the next few days. Thank you very much for coming.
Thank you. Excuse me, if I could just have all media remain seated while we escort our speakers out so they can get to the opening ceremony. Thank you so much.